Hi, today I am so glad to meet you in the program of JIP's Horse and Heart News. Yesterday, we received a patient with 4 days of fever. On clinical examination, we couldn't localize any reason for fever. Patient presented with fever, severe myalgia, raising the possibility of viral fever. Patient was subjected to complete blood count, which revealed total count of 3,200. So before we ordered complete blood count, patient was started on injection cephalosporin in view of high grade of fever. So just I want to highlight few things out of complete blood examination. Usually, before you order complete blood count, don't indulge in introducing any broad spectrum antibiotic. Of course, if patient has features of sepsis or septic shock, 1 hour within admission, the antibiotic to be started. Yeah, that may be the rule. But in a more stabilized patient, even in a septic shock patient also, complete blood examination results can be derived within half an hour. Generally, when WBC count reveals count less than 4,000, 99% it indicates some form of viral fever, which may exclude administration of broad spectrum antibiotic. When you have total count of 3,400 or 3,600 or even 2,800, anything lesser than 4,000 of WBC count, then definitely you have to assume viral fever. But in viral fever, you have so many viral fevers, but we are generally concerned about dengue, chikungunya, and COVID, and of course H1N1, flu and so on. But other viruses we are not really interested in evaluating, including respiratory syncytial virus and so on. But we have nowadays, there is an respiratory viral panel is there that includes 14 to 15 viral organisms are getting isolated. So that is a different one. But when you are in a periphery setup, after getting CBC done, when you have count lesser than 4,000, then probably it must be a viral fever. Then I think that you may be justified in evaluating viral fever rather than putting the patient on broad spectrum antibiotic. Among viral fever, when total count comes down, leukopenia always strikes in our mind in such a way that dengue should be brought to our mind as a first one. Yes, that is not the bad idea. Any patient count is less than 4,000, you have to order dengue NS1, which may detect the NS1 antigen at the earliest, as early as on second day of fever. So initial few days of dengue fever, you will have leukopenia alone. So thrombocytopenia will be evident only after third day of fever. So in the presence of leukopenia, even normal platelet count also, you should think dengue fever. Not necessarily, you can't expect leukopenia and thrombocytopenia in first few days of fever. But leukopenia present on 5th or 6th day, okay? But you are seriously suspecting dengue, but there is no thrombocytopenia, then probably you can think of enteric fever. It's a very, very common one. Many a time, our general practitioner are unaware of leukopenia which can be precipitated by enteric fever. But around 5th or 6th day, if you look at CBC count in enteric fever, you will have leukopenia alone, but platelet maybe most of the time platelet count is preserved, or it may be somewhere around 1.4 lakhs instead of 1.5 lakhs. But 5th or 6th day of dengue fever, you will have good amount of leukopenia. Parallelly, you will have thrombocytopenia, maybe less than 1 lakh also. That is the little bit difference between the complete blood count profile of dengue and enteric fever around 5th or 6th day. But first few days, enteric fever doesn't show leukopenia. But dengue fever can produce leukopenia even from 2nd and 3rd day onwards. But around 5th or 6th day, dengue fever will exhibit both leukopenia and thrombocytopenia. Thrombocytopenia may be severe in such a way that it may be lesser than 1 lakh also. But in enteric fever, most of the time you will have isolated leukopenia around 5th or 6th day, but you may not find thrombocytopenia. The another biggest clue of enteric fever is there will be eosinopenia. This one has been taught by Dr. Suresh Kumar, senior consultant in infectious disease. So he used to teach me such that in the presence of leukopenia, if you suspect enteric fever, if you look at eosinophil count, it may be lesser than 0.1% or 0.2%. I have witnessed many patients of having eosinophil count simply 0%. So eosinopenia will be a very strong indicator of enteric fever in the presence of leukopenia. Then apart from that, we are doing Vidal test on 2nd and 3rd day of enteric fever, which may not be warranted because it is an agglutination assay. Agglutinins will be formed only at the end of first week. But even at the end of first week, even if you do Vidal test, then you have to show serial elevation of titer rather than the isolated elevation of single Vidal test. So for all practical purpose, this leukopenia with profound eosinopenia in the presence of relatively normal platelet count or low normal platelet count may be favoring enteric fever. And another important investigation that has been ignored or neglected by our practitioner in evaluation of fever is liver enzymes assay. Generally, many of the viral fever, they strongly favor in attacking liver as well. Suppose in the presence of leukopenia around 3000 total count, if you do LFT test, at the time if SDOT, SDPT is marginally elevated, 100 SDOT, SDPT around 100, 120, it may favor dengue fever. Or when you during the time of leukopenia, you are strongly suspecting viral fever, dengue turns out to be negative, but SDOT, SDPT is somewhere around 300, 400, then it is leaning towards 800, 900, then probably you have to think of hepatotropic virus infection, namely hepatitis A and B and C and E and D and so on. So, in the presence of leukopenia with prolific elevation of SDOT, SDPT in the name of around 600, 700 international unit, then definitely you have to think of viral hepatitis. So last week, one patient presented with total count of 3000 with the provisional diagnosis of viral fever. Then I ordered dengue NS1, it turned out to be negative. So that patient usually she will show some kind of stringency in doing blood test. So I have restricted myself to dengue NS1 alone. Then once fever settled down, after 7 days, she continued to have vomiting. Then at that time, I did LFT, SGPT was around 900, SGOT around 800. So I immediately order hepatitis A alone because other virus may not be affordable. Then anti-hepatitis A IgM turned out to be positive. Why I am insisting this SGOT, SGPT elevation will be helpful in differentiating the etiology of the fever. So in the presence of fever, marked elevation of SGPT somewhere around 800, 900, then diagnosis towards hepatitis. But leukopenia with marginal elevation between 100 to 200, 250, then you can think of dengue fever. Of course, we are going to order dengue. But sometimes total count may be normal or you may have leukocytosis. But around you may have 300, 350 SGOT, SGPT. But don't forget leptospirosis and scrub typhus as well. Leptospirosis and scrub typhus, they have thrombocytopenia with leukopenia or without leukopenia, but elevated liver enzyme, then definitely you have to think of these two differential diagnoses. Most of the time what I have observed, the important clinical picture in the presence of leukopenia between dengue and enteric fever is, enteric fever patients, they are throwing lot of chills and rigor. And many of the times I have witnessed dengue fever, they will have profound body pain and back pain, of course, severe myalgia, and most of the time enteric fever patient, they will have good amount of chills and rigor, which may prompt you to think in such a way that you may have to order even malaria also. So that kind of chills and rigor is quite evident in enteric fever. So when you have leukopenia with chills and rigor in early days of fever, probably you can think of enteric fever and rather than dengue. Of course, we are going to order dengue serology, that is a different story. So these are the few things I want to enumerate, how to differentiate. And generally SGOT, SGPT somewhere around 1000 means you have to think of 3 important differential diagnoses with respect to infection, viral hepatitis. Sometimes ischemic hepatitis, when somebody suffers severe shock, BP is around 60 or BP is not recordable for 1 or 2 hours, then at the end of the day, if you do LFT, their SGOT, SGPT around 600, 700 because of profound ischemia to the liver secondary to shock, whatever the etiology. Then another differential diagnosis, sometimes drug-induced hepatitis, paracetamol can produce elevation of SGOT, SGPT to the level of around 1000. So these are the things I want to bring to your notice. Then one more patient we received yesterday with severe abdominal pain. Then routine investigation revealed urea is around 110 and creatinine 1.1. So duty medical officer informed me that, sir, patient has suffered renal injury and she has abdominal pain. So I am thinking in terms of some kind of pyelonephritis. Then I put some leading questions against him. Whether any history of fever in the past or now to suggest the diagnosis of pyelonephritis, he told no. Then where is the location of abdominal pain? He told the abdominal pain is predominantly in the epigastric region. Then I told, when you don't have pain at the loin, then how can you suspect pyelonephritis? Then he immediately told, sir, there is an urea creatinine, there is some kidney injury and abdominal pain. So my mind prompted to correlate for pyelonephritis. So but here the urea is around 110, creatinine 1.1. We could say there is a disproportionate elevation of urea and creatinine. So when you have disproportionate elevation of urea creatinine in such a way that when urea level is 40 times greater than value of creatinine, for example, you may have creatinine is around 1.5, but urea is around 80 or something, this kind of disproportionate elevation, it evokes always three differential diagnoses. One, patient is in pre-renal azotemia, possibly due to dehydration. If you correct patient with 0.9% sodium chloride, then if you repeat urea creatinine after 24 hours, definitely urea will come down. One. And second one, upper GI bleed. This is very, very important. We have been witnessing so many upper GI bleed with disproportionate elevation of urea and creatinine. This patient also actually presented with upper GI bleed, which resulted in epigastric pain, and this bleeding into the stomach irritated the stomach, resulting in diarrhea. So many a times I have seen somebody present with abdominal pain and diarrhea, even with black color stools. We never think of upper GI bleed. If somebody says stool frequency 5 or 6 times, we are always prompted to give injection ofloxacin and metronidazole. This one I have been witnessing so far. So this patient presented with abdominal pain, mainly localized to epigastric region, with diarrhea 5 or 6 times, but with black color stools. With urea more than 100, creatinine has been retained to a normal level 1.1. Then when I did the rounds, I checked the patient. She was so pale, hemoglobin around only 7. So patient gave history of black color stool. It's a straightforward diagnosis of upper GI bleed, because when you have upper GI bleed, the blood that has been collected in the stomach will be broken into hemoglobin that hemoglobin will be broken into globin and heme. From the globin is nothing but protein. From the globin, urea is derived. When kidney is normal, your creatinine is retained, but protein is relentlessly produced from the hemoglobin derived from broken RBCs present in the stomach. This is one of the reason for disproportionate elevation of urea and creatinine. Don't forget upper GI bleed. Then apart from that, dehydration and upper GI bleed, another important cause for disproportionate urea and creatinine is prolonged corticosteroid therapy. So prolonged corticosteroid therapy will make the patient entering into catabolic state. So proteins will be broken down, induced by prolonged steroids. So protein breakdown will give rise to disproportionate urea elevation. So these are the causes you have to keep in mind. Then last session I told one patient presented with hemoglobin around 7 gram, but her MCV is around only 85 femtoliter, that means normal MCV. So I didn't think of iron deficiency anemia. I didn't think of megaloblastic anemia. So normal MCV, I told 3 differential diagnoses: anemia of chronic disease and combined vitamin B12 and folic acid deficiency, and third one hemolysis. Patient had splenomegaly, so we suspected hemolysis. We did reticulocyte count, that is more than 7%. So indirect bilirubin was very high. So all these features favored hemolysis. Peripheral smear shows numerous spirocytes. We checked osmotic fragility test to rule out hereditary spirocytosis. Fortunately, osmotic fragility test turned out to be positive. That means patient has hereditary spirocytosis. Since it runs in families, we checked their family members. 3 members out of 5 members turned out to be hereditary spirocytosis. With this update, I want to end this session. Thank you.